السلام عليكم. اليوم راح نتكلم عن الطحال. So the overview of the lecture about the spleen will be talking about the anatomy, physiology, splenic trauma, and splenomegaly. The origin of the spleen, as you are aware, is from the condensation of the mesoderm from the dorsal mesogastrium. And just a quick review of the anatomy. It is the largest single mass of lymphoid tissue in the body. It has the size of a closed fist. It weighs about 75 to 250 grams. It lies in the left hypochondrium between the gastric fundus and the left hemidiaphragm, and the long axis lying along the 10th rib. The hilum sits between the angle in the angle between the stomach, kidney, and is in direct contact with the tail of the pancreas. Surface anatomy, as you are aware, the lower pole extends to the mid-axillary line, and there is an notch in the inferior lateral border, and that could be palpated when the spleen is enlarged. Here you can see the impression of the gastric the stomach on the spleen, and this is the colic impression, and this is the pancreatic impression. And this slide shows you that the pancreas, the spleen, is in a close contact with the stomach, the omentum, and the colon. And here it shows the ligaments attaching the spleen in the posterior part of the abdominal cavity. This slide will showing you once we remove the stomach, and you can see that the spleen is in direct contact with the splenic flexure, with the pancreas, and you can see here behind the kidney. The splenic ligament, just to remind you, there are three main splenic ligaments: gastrosplenic, glenorenal or splenorenal, and the splenocholic ligament. Probably the most important one, which carries the blood vessels, is the gastrosplenic ligament, which passes through the greater curvature of the stomach to the spleen and contain the blood supply to the spleen, including the splenic artery, vein, and short gastric vessels. This slide shows you the surface anatomy as well as the ligament attachment, and you can see here that the gastrosplenic ligament, and inside that ligament there will be the blood supply and the venous drainage of the spleen. The blood supply to the spleen, as you are aware, is mainly from the splenic artery, which arises from the celiac axis, and the artery usually runs over the superior border of the pancreas to reach its destination. In addition, the short gastric and the left gastrogastric artery also supply the spleen. The splenic artery divides into the hilum of the spleen into superior and inferior branches before it further branches inside the spleen itself. And this slide just to illustrate the tortuosity of the splenic artery, and as well it shows the left gastrobiblic and the short gastric arteries supplying the spleen. The venous drainage is from several tributaries combining together to drain once reaching the hilum, and then the splenic vein will run behind the pancreas, receiving the inferior mesenteric vein, then joining the superior mesenteric vein to form the portal vein. And here is a slide to illustrate a posterior view of the spleen and the pancreas and the stomach, and you can see here that this is the splenic vein running behind the pancreas, and shortly it will join the inferior mesenteric vein, and then after a while it will join the superior mesenteric vein to form the portal vein. behind the head of the pancreas. The lymphatic drainage comprise efferent vessels in the white pulp that run along with the arterioles and emerge from nodes at the hilum, and these nodes will drain eventually via the retropancreatic nodes to the celiac nodes. And the nervous supply is from the celiac plexus, which will innervate the splenic arterial branches. The histology of the spleen, the cut surface of the spleen will show you red pulps and white pulps. Within the red pulp, you'll see white 1 millimeter diameter white circles called the white pulp or Malpighian bodies, and the splenic pulp is invested by external serous and internal fibroblastic coat. And this slide just illustrates the histology of the spleen. The function of the spleen, we used to think that the spleen did not serve much function, and surgeons tended to take the spleen light, to do splenectomy without thorough thought about it, but now we try to preserve the spleen as much as we can, as we are aware that it carries numerous important function. In addition, removing the spleen unnecessarily might increase the mortality and morbidity. Now, just to enumerate the function of the spleen, immune function probably is the most important function, as it's the major site for formation of the IgM antibodies, and they are from B and T cells origin. And as you are aware, the IgM antibodies help to attach to specific receptors on the macrophages and leukocyte, and that will help phagocytosis and bactericidal and tumoricidal activity. Also, the spleen has non-specific function in non-specific opsonins, properdin and tufstin, and these are important for the immune system. The filter function, it helps to filter the blood from cellular and non-cellular material in the blood and the plasma. For example, defective platelet and red cells are filtered away from the circulation. In addition, non-cellular material such as bacteria also filtered by the spleen. Pitting, which is the function of removing inclusion bodies from red blood cells, such as Holzheuly and His bodies. Reservoir function, probably this is not a major function in human beings, but still we are aware that the spleen holds about 8% of the red blood cell mass inside, and that can be utilized at the time of need. Cytopoiesis, it's important for hematopoiesis early in the fetal life, but that function will be less after childbirth. This slide just to show you the indication for splenectomy. The major 4 indications are trauma, hematological disorder, or during other major oncological procedure, and miscellaneous causes or indication for splenectomy. Probably the spleen is the most common organ to be injured in abdominal trauma, and the two major or two mechanisms of injury could be either closed trauma or open trauma. And the presentation, usually the patient will have initial shock, then lucid interval, then further bleeding, and in showing again of the shock. Stages of shock, we'll come to speak about that in a minute, but here generally the patient will be tachycardic, hypotensive, hypothermic, oliguric, and locally by inspection there will be ecchymosis, bruise. You could feel rib fracture and abdominal distension. The abdomen will be rigid and tender, and percussion you might elicit shifting dullness, and auscultation there will be diminished bowel sounds. PR examination, you could feel fullness in the retrovesical pouch or Douglas pouch. And here this slide will show you the classes of hemorrhage, and that will help you to estimate how much the patient has bled and how to proceed in the management. Very important slide to remember. These are special signs: Kerr sign, balance sign, and Collins sign, that will help you to establish the diagnosis of splenic injury. The risk of splenic injury is higher in children and patients with pathological spleen, i.e. splenomegaly. And here are some of the causes of splenomegaly. The main categories are infection, immunological inflammatory disorder, hemolytic anemia, immunothrombocytopenia, portal hypertension, etc. Now, how would you treat a patient with splenic injury? ABC is the main principle: airway management, make sure that the breathing is adequate, and then attention to the circulation. If the patient is unstable and they have peritonitis and hypotensive despite fluid resuscitation, then there is no room for imaging. Those patients need to be taken to theater, and the spleen should be removed immediately. In the other category, the patient who are hemodynamically stable, then imaging plays an important role. As the CT scan is very sensitive and specific for splenic injury, and if the patient is hemodynamically stable, then the majority of patients could be treated conservatively without the need to remove their spleen. And the CT scan, it can give you a grade for the degree of the injury: 1 subcapsular hematoma, 2 superficial tear, 3 is deep tear, 4 there is a bulging of the pole of the spleen, 5 there is the complete depulping of the spleen without involving the hilum, class 6 is injury of the vascular pedicle or disruption of the spleen. Vaccination is important before you do splenectomy, especially for pneumococcal vaccination, and that should be repeated at 5 years. Haemophilus influenza and meningococcal also should be given with the pneumococcal vaccination, and the vaccine should be given 2 weeks prior to the surgery, and if it's an emergency procedure, as soon as possible after the emergency procedure. Antibiotics should be given lifelong, such as penicillin. Potential complications of splenectomy include bleeding, gastric dilatation, pancreatic fistula, subphrenic abscess, and the most serious is overwhelming post-splenectomy infection.